A 62-year-old man arrives at the emergency department with severe abdominal discomfort that has been worsening over the past 24 hours. He describes the pain as crampy, intermittent, and coming in waves. Between these painful episodes, he feels bloated and extremely uncomfortable. He reports nausea and has vomited multiple times. The most concerning detail is that he has not passed stool or gas since yesterday. On further questioning, he mentions a history of abdominal surgery for a hernia several years ago. He also says this pain feels different from anything he has experienced before. He denies fever but reports progressive abdominal distension. On examination, he appears dehydrated and restless, frequently shifting positions in an attempt to find relief. His heart rate is 110 beats per minute, and his abdomen is visibly distended. When the stethoscope is placed on his abdomen, the classic high-pitched tinkling bowel sounds are heard, a hallmark of early mechanical obstruction. In more advanced cases, bowel sounds may become absent. Gentle abdominal palpation reveals generalized tenderness without rebound. No guarding is noted, but the tight balloon-like distension is obvious. A digital rectal exam shows an empty rectum. An abdominal X-ray is performed and shows multiple air fluid levels with dilated loops of small bowel. A classic stacked coin or stepladder appearance. A CT scan provides more detail. It reveals a clear transition point with dilated bowel proximally and collapsed bowel distally, suggesting a mechanical small bowel obstruction, likely due to adhesions from his previous surgery, the most common cause in adults. Small bowel obstruction occurs when something physically blocks the intestinal lumen. Common causes include postoperative adhesions, hernias, tumors, and, less commonly, volvulus or strictures. The blockage leads to fluid accumulation, gas buildup, and increased pressure, which can compromise blood flow and lead to bowel ischemia if not treated promptly. This patient is started on aggressive intravenous fluids for dehydration and has a nasogastric tube placed to decompress the stomach, relieving pressure and reducing vomiting. He is kept NPO and closely monitored. Surgical consultation is obtained immediately, as some cases require urgent operation, especially if there are signs of strangulation, ischemia, or peritonitis. Key takeaway: crampy abdominal pain, vomiting, distension, absence of stool or gas, high-pitched bowel sounds, and dilated loops with air fluid levels on imaging strongly suggest intestinal obstruction. Early recognition and rapid management are critical to prevent bowel ischemia and perforation.